Hello and welcome to this educational presentation from Professor Mohammadi's teaching archives. We will explore a clinical reasoning challenge involving a child with a slowly progressive peripheral neuropathy and an unexpected cerebral white matter lesion. Our goal is to determine which inherited neuropathy can unify these findings and which investigation will provide the most efficient confirmation. As we proceed, notice how the family history, neurological examination, and MRI progressively narrow the differential diagnosis. Next slide. This case illustrates an important intersection between peripheral and central nervous system disease. Recognizing Charcot-Marie-Tooth disease alone is not enough. We must identify the molecular subtype that can plausibly explain both the inherited sensory-motor neuropathy and the cerebral white matter abnormality. The challenge is therefore to integrate the phenotype, inheritance pattern, and neuroimaging rather than considering each finding in isolation. Next slide, please. At 3 years of age, the child appeared to have normal strength, gait, cranial nerve function, and sensory examination. However, his ankle reflexes were difficult to elicit, an unusual finding at that age and a possible early sign of peripheral neuropathy. By 12 years of age, the phenotype had become much clearer. He was clumsy and slow at running, with distal hand wasting, weak ankle dorsiflexion, diffuse hyporeflexia, and impaired distal proprioception. Difficulty walking on his heels further supports dorsiflexor weakness. The gradual evolution over 9 years strongly favors a chronic inherited sensory-motor neuropathy rather than an acute inflammatory disorder. The pedigree is not simply background information, it is a major diagnostic clue. Several affected individuals are present across the maternal lineage, including both males and females. Although this pattern might initially appear inconsistent with an X-linked condition, CMTX1 commonly manifests in heterozygous females. Their symptoms are often milder and more variable than those of affected males because of differences in X chromosome inactivation. Therefore, the presence of affected women does not exclude X-linked inheritance. This multi-generational maternal pattern should move GJB1-related CMT much higher on our differential diagnosis. Next slide, please. The neurological examination localizes the principal clinical problem to the peripheral nerves. Both motor and large fiber sensory functions are affected, with distal involvement greater than proximal involvement and a slowly progressive course. Nerve conduction studies would help confirm the neuropathy and determine whether the physiology is predominantly demyelinating, axonal, or intermediate. However, electrophysiology alone may not identify the causal gene. At this stage, several CMT subtypes remain possible. The critical question is whether the cerebral MRI finding is incidental or represents another manifestation of the same inherited disorder. A solitary T2 hyperintense white matter lesion could suggest an incidental finding, inflammatory demyelination, or a metabolic disorder. In this patient, however, it occurs in the context of a convincingly inherited sensory-motor neuropathy. The GJB1 gene encodes connexin 32, a protein expressed in peripheral myelin and relevant central nervous system cells. Consequently, CMTX1 may involve Schwann cells, peripheral axons, and cerebral white matter. Transient or monophasic white matter abnormalities are recognized manifestations of this subtype. The absence of adrenal, pyramidal, visual, or inflammatory features makes competing explanations less coherent. The preferred diagnosis should explain the pedigree, neuropathy, and MRI together. Next slide, please. Now, consider which investigation would most efficiently establish the unifying diagnosis. PMP22 duplication analysis is tempting because CMT1A is the most common demyelinating form of CMT. Plasma very long-chain fatty acids could evaluate X-linked adrenoleukodystrophy, while cerebrospinal fluid oligoclonal bands might investigate an inflammatory demyelinating disorder. Broad whole genome sequencing is increasingly valuable but may be unnecessarily broad when the phenotype already points toward a specific gene. Take a moment to choose the investigation that best integrates the maternal inheritance pattern, peripheral neuropathy, and central white matter involvement. Next slide, please. The best answer is targeted GJB1 sequencing combined with deletion and duplication analysis. This is a phenotype-directed decision. The maternal multi-generational pedigree supports X-linked inheritance. The mixed sensory motor neuropathy is compatible with CMTX1, and the white matter lesion is a recognized central manifestation of GJB1 related disease. PMP22 testing would be appropriate for a typical, uniformly demyelinating neuropathy without central nervous system findings, but it does not adequately unify this case. If focused GJB1 analysis is negative, broader panel, exome, or genome sequencing would then become appropriate. Comprehensive testing should extend careful clinical reasoning rather than replace it. Next slide, please. Once the molecular diagnosis is confirmed, coordinated care becomes the priority. The family should receive a clear explanation of X-linked inheritance, including the variable manifestations seen in heterozygous females. Genetic counseling can address testing of relatives, reproductive implications, and the benefits and limitations of presymptomatic testing in children. Functional care should include physical therapy, appropriate orthoses, orthopedic surveillance, injury prevention, and assessment of participation in daily activities. Longitudinal follow-up through a multidisciplinary neuromuscular clinic can coordinate neurological, rehabilitation, orthopedic, and psychosocial needs. The central clinical message is that CMTX1 is primarily a peripheral neuropathy, but may also involve the central nervous system. Thank you for watching. This educational presentation has come to you from Professor Mohammadi's teaching archives. I hope this case has demonstrated how thoughtful integration of the pedigree, neurological examination, neuroimaging, and molecular testing can transform a complex presentation into a focused diagnostic decision.